give you some time to fix your techniques, and we will call on the next speaker, so you've got plenty of time to try to improve your devices. Don't panic. I'm sure you'll manage this. In the meantime, I'm very proud to call our next speaker. So we travel to Northern America, and the next speak will be by Dr. Kirk Lin, and he will report on molecular testing and precision medicine in prostate cancer. Dr. Kirk?
Okay, let me try to click the, well, it's early for me, but Christmas comes early. I should click share screen, share.
Very well, we can hear you and
Can you hear me now?
Yes, we do.
Okay, and let's see. Yes. Can you see my screen?
Yes, perfect.
Okay, good, great. Okay, good morning. It's morning my time. It's in the afternoon your time. Thank you for this opportunity to present some of my work and my review. I have nothing to disclose. I am a GU pathologist working at a largest group in the United States. We have about 200 providers in multiple locations. This presentation is for education only. These three professors contribute fair amount of contribution to my child, Dr. Lin from University of Washington, Dr. Evans from UC Davis, and Dr. Rader from UCLA. Today, we will go over briefly a few subjects: biomarker and screening, molecular risk assessment, genetic testing, and counseling. And if we have enough time, I will talk a little bit about precision medicine. Prostate cancer is the most common skin disease and second leading cancer death in the States. 1 of 6 men will have prostate cancer during their lifetime, and 1 of 36 of them will die of it. There are about 200,000 new cases this year. PSA is still the most common test available and still is, but it's not specific. There are several molecular-based tests available to provide more specific tests. These are the list of some of them, and there are still more in developing. PCA3 is a protein and is 60 to 100 times higher in prostate cancer than benign prostate. Also, it is more specific. So this is the diagram. The way we do it, you need to massage the prostate, collect the urine, and run the test. They test as mRNA, and express as the ratio of mRNA versus PSA mRNA. There's noise in it. There's less noise, I'm sorry. Let's go back to the previous one. Now, all these tests are different. The second one is the Michigan prostate score. It tests 10+2 ERG and PSA3 gene. Select MD tests 2 genes, and Confirm MD tests 3 genes. 4K score is a combination of 4 different proteins, and ExoDx tests 3 genes. The last one is single nucleotide polymorphism. Now, the PSA currently is very popular in my practice. And if you see from this figure, there's a sharp difference. At the reading at 35 is above 35, there's more likely probability to have cancer. So the cutoff level is set at 35. The sensitivity and negative predictive value is above 90. So I always explain to the clinician that the easy way to remember this is that if the PCA score is 40, and there is about 40% probability to have positive biopsy. If the PCA3 score is 70, and there is a probability 70% to have positive biopsy. It's easy to remember this way. Now, if we plot into a AUC figure, so PCA3 has about 0.865, which is very high. Next one we are going to talk about a little bit is select MDX. Both select MDX and confirm MDX are from MDX Health. Select MDX is for before the biopsy. Equivalent is similar to like PSA before you do the biopsy. And the confirm MDX is after you do the biopsy. If the biopsy is negative, and then you run the confirm MDX. Now, when the first time when you have biopsy, if it's negative, and usually the patient will have some anxiety or something. So it's better to run the test and confirm MDX addresses the biopsy sampling error and false negative dilemma. This is the one we use in my practice. As I said, we have 200 providers. And this is the cutoff level for confirm MD, 15.8. And this test is a well-validated epigenetic test that guides the detection of occult prostate cancer on the patient previously negative biopsy tissue. If confirmed MDX is negative, and then you don't need to do the immediate biopsy, you just need to watch the patient. Next one we are going to talk about is ExoDX. This is newest one from the list, and this is the most promising one because it is relatively specific, and also it uses regular urine. You don't need to do the DRE. All the other you need to do some sort of procedure like a DRE, biopsy, or blood draw, or a swab or something. But this one just use regular urine. And they test mRNA or PCA3 protein, 10+2 ERG, and ETS transcription factor to predict high-grade cancer. The sensitivity and negative predictive value is also high, above 90%. And this is the flow chart for this test. The indication of the test, how it works, and how to use it is all here. Now, if you use ExoDX combined with MRI, you can see that you don't miss any high-grade cancer. At the same time, you avoid about 10% of unnecessary biopsies. Finally, we talk a little bit about single nucleotide polymorphism SNPs. It is a DNA sequence variation occurring when a single nucleotide differs from the norm. It carries some risk of prostate cancer or in any other cancer, not only prostate, and is kept through the heredity. There are slightly more than 100 SNPs identified through genome-wide association study, and this may provide an excellent way for population-wide screening However, this is relatively new and still ongoing study. Here again, we see this table again that different urologists use different things. But as I say, the PSA is still the king. Here's why. There are some disadvantages of these tests. One is these tests can only predict high-grade cancer, but low-grade prostate cancer may undergo undetected. Two, these tests can only perform at one or a few centers only. It is not practical for population screening. Three, these tests are very expensive, ranging from $300 to $2,500. Now PSA, it costs only $50, and you can do anywhere in any lab, even in the outpatient clinic. The current practice pattern in my practice is that if the PSA is high, we do the biopsy. If the biopsy is negative, and then we run the confirmed MDX or PCA3. Now, this is, I forgot to move here. Now, so let me ask a question. In your mind or to your experience, what is your PSA level? What do you think is the cutoff level? Please type in the question box, and I will answer this question later on. What is your normal PSA? Do I see anything now? Let's move on. Now, next topic, the same topic, but the different session is genomic assays for localized prostate cancer. This is a huge market because prostate cancer is a slow-growing disease, and a lot of men with prostate cancer will not die of it. Therefore, active surveillance is an excellent way to manage this. NCCN guidelines recommend any form of molecular analysis to confirm the candidacy for active surveillance. Here are the major available tests: Polaris from Myriad Genetics, Oncotype from Genomic Health, Decipher from Genome Diagnosis, Protovision from Basri Lab, ProMark from Metamark, and PTEN Plus from myself. PTEN Plus is a cocktail test I put it together. Now, Protovision uses 2 markers only, and because it's high false positive, false negative, that people don't use it anymore. ProMark also, I don't see anybody using in my practice. So we basically will talk about in detail of 3 or 4 tests. And here is the screenshot from NCCN guideline. It shows that low-risk cancer should, let's see, can I see anything here? Yeah, so molecular analysis should be recommended for low-risk cancer. Let's take a look closer. Okay, I put things together closer. Prostate cancer is heterogeneous, genetic, and multifactorial. The biologic risk and biologic behavior is very important, but not included in the NCCN risk grouping. Sometimes a low-grade prostate cancer may harbor aggressive malignant cells. On the other hand, sometimes some of the unfavorable intermediate may be silent. Therefore, there's a need to measure the biologic behavior of the cancer cells. So here's why there are so many new tests available, and there are still more in developing from different companies. And here is the comparison of the 4 tests we use most common. They all provide similar prognostic information: Polaris, Oncotype, PTEN Plus for my own, and Decipher. They all report the risk of the prostate cancer, the probability of the disease progression, and 10-year survival. If you look at the bottom, the cost is different. And the test I created cost the least. Now, here is the genes or components of each test. The preliminary is tested 31 genes. It's all related to cell cycle progression. Oncotype is 17, and P10 plus tested 6 markers, P10 tumor suppressing gene, ERG, P67, as we all know, P27, MAC1, a T-cell protein, and P53, of course, oncotype mutation. Now, Decipher tests 22 genes. Decipher is based on the protective specimen, it's not designed for biopsy. I'll come back to the test I test here that the reason I put this test together is I feel the test I have is from different aspects of the malignancy, and also it is a sort of global evaluation of malignant cells, like it consists of molecular, immunohistochemistry, and cellular component. So it's more rational this way. During the malignant transformation, different molecule events happen at different locations, such as P27 deletion here, ERG abnormality happens here, and P10 lesion right here. The P53 is down here. P10 is a tumor suppressor gene. If the P10 is deleted, the cells will grow unchecked, which is malignant. And ERG may be in the form of fusion, deletion, or insertion. This is a published data that you can see survival if the P10 deletion together with abnormal ERG, it has the poor, the worst survival. Another paper published from clinical cancer research, also showing P10 deletion and P27 deletion at the same time, had the what survival as well. Now, MUC1, MAC1 is a T-cell protein. If it is upregulated, it tends to have tumor progression and metastasis because a T-cell protein. A survival study, you can see that if the MAC1 is upregulated, it also has poor survival. People may ask, what does the P10 do? P10 plus in my own days, what does it do? How does it do? As compared to all the other test modalities, is a reminder that P10 plus test can consist of these components. And actually, these components are very familiar to our pathologist community. So here is the initial data. I just studied this year. I don't have many cases yet. If you look at the low risk group here, they are very comparable. About half of the patients we tested, half of the patients can be safely in active surveillance. And again, this data has been accepted to present at next year United States Canadian Academy meeting next year in Baltimore. Because it's again it's online. Now, what is the significance of all these expensive tests? The test is quite expensive, about 4,000. The only the test I have is about 1,000, but still expensive. Is it worth for the money? So let's talk about this figure. In the past, when a man has newly diagnosed prostate cancer, they are clue what to do. So most of them will receive aggressive treatment like prostatectomy or radiation. Now, with this test available, we'll be able to measure the risk of cancer. So more than half the patient can be at active surveillance. So they don't do anything, just watch every year or follow up biopsy once a year. This is huge savings, of course. And also that so-called over-treatment is not the question, it's out of the question anymore. People keep complaining there's over-treatment, over-diagnosis. I don't think so, because we find the cancer, we watch them, we don't need to do anything after the test. So let's take a look at actual two cases comparison here. And these two cases are almost identical, 65-year-old, PSA 4.7, normal DRE. Cancer involved 35% and 1 out of 12 core. The other cases are very similar. Or the recent grace material. Okay, now most of us are histopathologists. Please help me. I'm the pathologist as well. So let's assign the Gleason grading here. Take a look at the picture and get the Gleason grading. I'm sure all of you got it. As you can see here, that there are most large area of open glands, which is pattern 3. Also, there is tiny area, fused gland or needle-shaped glands, maybe 4. So these two cases, of course, 3 plus 4 is reasonable. Now, let's take a look. Let's take a look the molecular test gauging. The case 1, 3 plus 4, it is low risk on both tests, oncotype and P10+. So this man, we go to active surveillance. Now, next case, the same situation, but at high risk. And of course, you need to go to prostatectomy. So this is why this test is getting into practice. Now, and for this actual two cases, I went back to look at the slides. I still couldn't tell the difference. There's no difference on histology. So the benefit of active surveillance is maintain normal life, keeping normal workforce, healthcare savings. You know, some men will be never die of the prostate cancer. They may die of something else, but the prostate cancer may just silent there. And of course, overdiagnosis and treatment is out of question anymore. Now, I get this question all the time: what tests we should use and what on what patients? In other words, is what is the best bang for the buck? So, and then we need to go back to this table to take a look. Now, all these tests are most commonly used. The Decipher is designed for prostatectomy. It's rarely used for the biopsy, but people still can use it. They report similar information. They provide similar information. Oncotype has a little bit more edge here because it has it reports risk of high-grade cancer, also reports the risk of PT3 disease. Now, the tests I have are not much different, and it also costs less. The ranking at the bottom is for myself. I try to be as fair and as objective possible. For me, I'm not as good, but as time goes on, as I have more clinical investigation, you know, I show that this is one of the best. Our urologists use all the tests are available. The urologists under my direct surveillance use more P10+, while the other locations tend to use Oncotype or Polaris. Men with Gleason 3+3 and 3+4 are most applicable. Sometimes 4+3, the clinician TG wants it, and I run it for them if they order it. In summary, patient diagnosed with localized prostate cancer may face multiple decisions. Active surveillance is an excellent regimen for low-risk patients. Molecular tests for risk gauging is an effective way in selecting patients for this purpose to ensure patient safety. Now we are moving to next session, genetic testing and counseling for prostate cancer. In this session, we'll answer the question why, who, when, and how. Probably you've seen this before. We have discussed biomarker screening and risk assessment. Some of you may have heard of genetic and genomic testing for metastatic prostate cancer. Recent development shows that genomic mutation happen throughout the entire spectrum of the disease, even at early stage of the localized prostate cancer, throughout the entire spectrum. When this happens, the malignancy is usually high-grade, aggressive, and sometimes it goes through family pedigree. As we all know, the somatic mutation can happen in any cells in the body and is not inherited. For germline mutations, it happens in the eggs, inherited in every cell in our body and passed on in the family. Carcinogenesis is multifactorial. Some genes confer very high risk, others don't. Some mutations are common but have a low impact on prostate cancer. Some rare but with high penetrance as those in this area. These mutations showing in this area has large impact on prostate cancer. The majority of prostate cancer is sporadic. Only about 10% are hereditary, and that are usually due to single inherited genes, single inherited mutations such as BRCA1 or BRCA2 or MSI. MSI is part of Lin syndrome. The lifetime risk is greatly increased, and the cancer is usually aggressive. This is almost a landmark paper from New England Journal of Medicine. They reported about 12% of metastatic prostate cancer and maybe as high as 20%, and 5% of localized prostate cancer of germline mutations. And this is significant because these cancers are aggressive. When germline mutation happen, there is about 10-fold more rate to develop cancer. And again, these cancers are high grade, aggressive, and usually metastatic with poor survival. This is why and where the genetic testing come in. Family history is very important. It goes beyond prostate cancer. It includes breast cancer, ovarian, colon, endometrium, leukemia, etc. And so in clinics, for the clinician, they need to detail history. Here is the example of a family pedigree of BRCA2 mutation. A mother died of breast cancer, or a daughter died of ovarian, another daughter died of breast, and down in the line, a son or grandson is a prostate cancer subject, and you see down the line a lot of them. The NCCN guideline recommend familial assessment of following situation. So this is not only prostate cancer anymore, it includes everything. So if there is a metastatic prostate cancer, you need to do the genetic. If there's a personal history of Gleason 7 with one close blood relative with ovarian, pancreatic, or metastatic other cancers, or two relatives with breast or prostate cancer at any grade or as Jewish ancestry, and introductory or pre-preformed prostate cancer is always indication. Now, I summarize this just for the prostate cancer only, that as you can see, the high-grade cancer and metastatic also are always recommended to have a genetic testing for low-grade cancer, low-risk cancer. If there's a strong family history, of course, you need to do that as well. Multi-gene testing is recommended. Here is the list of the genes mutation here. BRCA2 is most common one. But if you test 10 genes, it covers 95% of the entire mutation. So you cover everything. A study from Europe on more than 3,000 men at young age, aged from 40 to 69, when the PSA is higher than 3, they did the biopsy, and they showed that those men with BRCA2 mutation have 3 things. 1, higher incidence of prostate cancer. 2, young age at diagnosis. 3, high grade. As you can see on the left here, that these are BRCA2 mutation carrier, and the cancer are used, half of them are high grade, 3+4 or 4+3. On the right are non-carrier subject, that most of them are 3+3. And of course, most of you are histopathologists, and these are the pictures of histology. Obviously, 4+3 here and 3+3 here. The survival study shows that BRCA2 and BRCA1 mutation, who is prostate cancer, shows worse survival in these two here. It happens to localized and metastatic prostate cancer. The germline mutation status can guide chemotherapy. Patient A developed drug resistance. The PSA went up here. So they run the mutation test and find the mutation. They switch the chemotherapy and add carboplatin, I believe, and bring the PSA down and relapse, and add another cycle of chemotherapy. Patient B, you see that there was a drug resistance right here and PSA relapsing. And here again, they tested that Germline mutation and switched or added another chemotherapy. And the PSA, the sharp decrease here. Elaprib is a new drug that just approved for prostate cancer. This is case report. As you can see, the PSA keeps rising. Nothing is working. The PSA has been rising until they test the Germline mutation right here and add the switch to a new drug, elaprib, and you see the sub decrease of PSA here. And the test is done right here, I believe. Because the germline mutation, that triggers a genetic counseling and cascade testing for siblings. This man has germline mutation with prostate cancer, and he will have new treatment, of course. At the same time, the entire family siblings should get genetic testing and counseling. Now, a few minutes ago, I asked you about the normal PSA cutoff level, and now let's talk about it. The PSA cutoff level is changing depending on family history, personal DRE, this director examination, and two surprise here. Generally speaking, for general population, 2.5 is the cutoff level for PSA. However, for mutation carrier, the PSA could be as low as 0.75. So if PSA above this level, we need to screen those subjects. To be honest with you, I've seen prostate cancer with the PSA of 0.5. In summary, 12% of men, and probably as high as 20% with prostate cancer, with metastatic prostate cancer, and 5% of men with localized prostate cancer inherited germline mutations. All high-risk cancer should be tested. Multiple gene panel is recommended. Cascade testing for family members should be in place as well. Inherited susceptibility to prostate cancer is important across the entire spectrum of the disease, from screening to advanced cancer. Now we are moving to the last part. Let me take a look at time. I don't know how much time I have, but I should have enough time. Maybe I run too fast, but that's okay. Now we are at the last session, precision medicine in prostate. Are we there yet? You've seen this before. The molecular events of prostate cancer happens all along from begin, from early to the late, from localized to advanced disease. And NCCN recommends NCCN risk group are overlapped. These groups are overlapped and not truly representative of the actual molecular nature of the disease. So precision medicine comes into field gap. It involves from population screening, genomic diagnosis, risk assessment to therapy and surveillance. Generally speaking, the all three parts we just discussed previously are part of the precision medicine, like molecular biomarkers, genomic risk assessment, and genetic testing. But in this session, we mostly focus on therapeutic applications of precision medicine in prostate cancer. As we all know, we are in the field of diagnostic pathology, and this may be beyond my capacity to discuss in depth. And I will just do some brief introduction. There are many somatic genes, somatic mutation and germline mutation prostate cancer. Some of them can be used for diagnosis or prognostic analysis. Others may be used for targeted therapy. So here is the list of the somatic mutation. You will see a lot of them. And here again is the list of germline mutation. Precision medicine in prostate cancer is actually far behind lung cancer, breast cancer, and colon cancer. So we are actually playing catching up. Our goals are to perform molecular interrogation to provide insights into tumor biology and treatment. For population-wise, to accumulate genomic data and identify patterns and pathways, and ultimately for individual patients. There are many mutations during the course of molecular transformation. Some of them are actionable, some of them don't. These actionable mutations can be used as therapeutic interventions such as AR pathway or DNA repair defects. If we use DNA repair defect as a biomarker, and we take a look at these two group patients here, that the biomarker positive, which is DNA repair defects, it responds better on the new drug olaparib. On the right side, I'm sorry, on the right side, that on average, it lives 4 months longer than the previous one, and there's a clear separation. There's a clear separation of these two groups. The blue line is the subject biomarker positive subject on olaparib. The histology diagnosis and classification are still the gold standard in practice. However, when it comes to high-grade prostate cancer or metastatic prostate cancer, the histology evaluation is not good enough. There was a study of 300 men with metastatic prostate cancer. They found that 39% of them had different molecular profiles and defined as atypical, intermediate carcinoma, and 12% has small cell neuroendocrine carcinoma. So they found 61 gene signatures in treatment-induced small cell carcinoma. These 61 genes are plotted into a panel, and here it shows the green area on the left upper is a treatment-induced small cell carcinoma, and the regular adenocarcinoma is the yellow area. So this gene signature is able to differentiate between these two histology groups. Now, these findings may and can translate into patient care. The figure on the left is the survival of non-treatment induced. It's slightly better. Now, but the difference is very small. You can see the 45.5 versus 36.6. Now, if you look at the gene signature classification, that there's a big difference here. That is 41.7 month survival versus 17.6 survival. So this is a significant again. So this tells us that the gene signature is much more definitive in determining the outcome of the patient with treatment-induced small cell carcinoma. The current genomic bridge test, like Polaris Oncotype or P10+, we have discussed in part 2, are still in version 1. The future genomic test will be version 1, which will be the combination of Gleason score, clinical prognostic signatures, and hallmark gene through next-gen sequencing. Here is what it mentions, how it looks, that all the information, including Gleason score, clinical prognostic signatures, and hallmark genes, are plotted in the grid. And the artificial intelligence will find the risk profile for each specific patient. In conclusion, the precision medicine in prostate cancer based on genomic is exciting and has a bright future. Although the current application is still limited, the influence across the genome are vast and complex, and are still at the early stage of development. Genomic data correlates with histology has important role at real practice. Combination of genomic mapping with Gleason score and other clinical prognostic signatures can provide more and better therapeutic and prognostic information. The take-home message for all 4 parts of presentation today are several molecular tests available for prostate cancer screening. However, PSA is still the most favorite method. All the other molecular tests are mostly used on negative biopsy patients. For patient safety, NCCN recommends molecular gauging for active surveillance, and this is the state of the art in practice. Germline mutation and somatic mutation happens throughout the entire spectrum of the disease. Genetic testing and counseling are recommended if clinical indicated. The precision medicine prostate cancer is promising, although it's still in its early stage. Thank you for your attention.
Thank you, Dr. Kirk, for your very comprehensive